Our first speaker is Dr. Ashish Kaushal, Senior Consultant Medical Oncologist. Over to you, sir.
Can I share my screen?
Yes, sir.
Yeah. I hope my screens are visible now.
Yes, it is visible, sir.
Unknown caller.
So thanks for Astra for inviting me. Sorry for the confusion, and I think it's better we can go through with the brief of the small cell lung cancer, the current treatment options, and what we have the options as of now today. And it would be great, Dr. Noemi will give further after this talk. So as we know, the lung cancer is one of the leading cause of the cancer-related death. And out of these two types, the non-small cell lung cancer is the most common, while the small cell lung cancers account for around 15-16% cases of that. This cancer is basically for elderly populations. Majority of the patients are diagnosed at the age of 60 to 70. And the brain metastasis is very common. It's up to the 50% of the patient they have the brain metastasis during the course of the treatment. And mostly this cancer is for the smokers. More than 90% patients are having the history of smoking. If we see the globally, the small cell lung cancer is around 15% of the cases, around 250,000 new cases been diagnosed globally every year. And almost the similar incidence we see in India. This cancer is associated with a very high mortality rate. Majority of the patients are presented in the extensive stage rather than the localized cancer. And this cancer is associated with poor cervical outcomes. Most of the patients die within 2 years of their diagnosis. And this leads to around 30,000 deaths per year. It's very lethal cancer. As I mentioned, majority of the patient diagnosed in the age of 60 to 80, and in the US, it is around 69 years. In our country, it is little early, so most of the patients are diagnosed in the age of 5 to 6 decade of their life. Various staging system will be used for the lung. They have the TNM system, but the most commonly used for VLSC system, which divides the small cell lung cancer, is the limited or extensive stage. The limited stage is basically the disease which is limited to the one part of the hemithorax, and this can be covered with the radiation, and that covers in the radiation port. And then 1/3 of the patient will see this kind of presentation, while majority of the patient having the disease beyond the limited stage, that is called extensive stage, and 2/3 of the patient being presented in this stage, and that's leads to a more aggressive treatment and the poor outcome. So if you see the incidence of the small cell lung cancer, 2/3 of the patient is diagnosed with the advanced stage, and our country is around 80% of the patient actually were present with the extensive stage of the lung cancer. More than 2/3 of the patient having the more than one side of the metastasis, and that leads to the more aggressive presentation and the fatal outcome of the disease. So the treatment options for the limited stage, very few patients we see in our practice who can be candidate for surgery. That is only for T1, T2 patients. Majority of the patients that require a combined modality treatment, that is chemoradiation for the limited stage small cell lung cancer. While in extended stage, they usually require a systemic therapy, chemotherapy, or with immunotherapy would be the standard of care for this category of the patient. And of course, those patients who responded with the limited with the systemic therapy, they can be treated with the PCI and the thoracic radiation for the patient having limited, this is limited to the thorax after the systemic treatment. So the current standard for extended stage small cell lung cancer, actually we have initially the cisplatin and etoposide is gold standard we are using in almost more than 3 decades or 4 decades, what you can say. It has been in practice since 1985. Very little development in the treatment options. We have etoposide in 1996, and then the carboplatin has been added for extensive stage small cell lung cancer. But in last 5-7 years, we have introduction of immunotherapy, and that has been changed in the management of small cell lung cancer. Unlike the non-small cell lung cancer, there is no major therapeutic advance other than the immunotherapy, because we don't have any molecular profiling-based treatment for small cell lung cancer. So there is an unmet need of a more new treatment options. So currently we have a immuno-oncology agent which is added with the chemotherapy to improve the outcome of extensive small cell lung cancer. And now with this introduction, immunotherapy has been changed the standard of care for the first line of the treatment of extensive small cell lung cancer. So if you see the approved immuno-oncology drugs, so we have two agents, that is the PD-1 inhibitors has been approved across the globe, and that is atezolizumab and the durvalumab with a combination of platinum and etoposide. And there is no the patient selection based on the biomarkers like PD-L1 status or expression for choosing the immunotherapy along with the chemotherapy in extensive small cell lung cancer, as there is no targeted mutations or based treatment for this category of the patient. For the general approach for the extensive small cell lung cancer, when the patient presented to the oncologist after the initial workup, that would be a radiological workup, a PET scan or CT scan or MRI brain. If the patient having extensive small cell lung cancer, then we need to start with the systemic treatment. And nowadays we combine with immunotherapy with the chemotherapy. So platinum etoposide with either durvalumab, atezolizumab is the standard of care. And those patients who is not a candidate for immunotherapy or because of the financial constraint, the platinum etoposide is the chemotherapy drug we can give. And based on the response, we can continue the further treatment. And after completion of 4 or 6 cycles of chemotherapy, the patient is put on the maintenance immunotherapy options. So in atezolizumab arm, this 3 weekly atezolizumab versus durvalumab every 4 weekly as a maintenance therapy. And so, the patient also received the PCI if the patient is the partial response or complete response, and the thoracic radiation for the subset of the patient. While those patients receive chemotherapy, there is no maintenance therapy, and unfortunately, majority of the patients going to relapse in a short period of time. So this category of the patient, they responded very well, but the relapse is very common. And if there is relapse within 6 months, we need to change the treatment. If the relapse is after the 6 months of the initial treatment, we can re-challenge with the same agents. So this is the key studies of checkpoint inhibitors, small cell lung cancer. Most of the studies is been phase 1 and phase 2, but those are the phase 3 studies like Empower 133 caption. So based on that, we have atezolizumab and durvalumab with chemotherapies in approved, and we are using in our practice. And while the phase 1, phase 2 studies, we have a single agent IOs or combination of nivolumab in checkpoint 032 studies. So that is only in the limited category of the patient as of now. Once the patient has been given the first line of the treatment, that is chemotherapy with the checkpoint inhibitors, and based on the response, the patient receive the further line of therapy, and those patients, they have either complete or partial response, they put on the maintenance therapy. And once the patient has been relapsed, they are the candidate for the second line therapy. As I mentioned, if there's a relapse early within 6 months, we need to change the agents, or if the patient is relapsed after 6 months, then we probably use the same agent. And as per guidelines, they consider more than 3 months at the sensitive disease, while in NCCN it is more than 6 months. So based on that, we need to choose our second line therapy. So two key studies, that is the caption studies in Power 133. So for the immuno-oncology agents, the caption study is basically a phase 3 open label, the randomized sponsored study, which is the combination of durvalumab with the chemotherapy. And this chemotherapy, they have been allowed cisplatin and carboplatin, both platinum is allowed for the study along with etoposide, and 4 to 6 cycles has been given. It's a 3-arm study, and it's compared with the chemotherapy, and durvalumab is another arm. And we have the data of the chemotherapy versus combination of the chemotherapy and durvalumab. And this study is a positive study. It's a median OS of 12.9 versus 10.5 months, favoring the combination of immunotherapy with the chemotherapy, and the HR is quite positive, it is 0.71. So we have a 3-year update with data, and at 3 years, we can see more than 3 times of the patient, that is 17.6% patient alive compared to 5.8% in the chemotherapy arms. So this is the first time we have seen anything better than the chemotherapy for small cell lung cancer. With this study, they have been allowed both the carboplatin and platinum as a part of the chemotherapy agent. So another study is Empower 133, and we have around 23 months update for the study. This is also positive study. The median OS 12.3 versus 10.3 is favoring the combination of atezolizumab with chemotherapy. And the study, the platinum agent they've taken is the carboplatin with etoposide. And the median HR is 0.76, and we have a 3-year update. Sorry, a 1.5 years update, and 34 versus 21% the patient has been survived for this study. So these two phase 3 studies, which is promising result, and we have been clearly showing the overall benefit this study, and other studies like Keynote 604 and Checkmate 84500 is also studied, but the magnitude of benefit is not significant in these studies. And currently we are using nivolumab and ezetimibe as a immuno-oncology agent in the first line therapy. Coming to the locorenal small cell lung cancer, so we have a very small population of the patient and present in our clinical practice. That is usually 15 to 20% of the patient, but those are the patients who are diagnosed in the limited stage. I think these are the patients first we need to look what curative treatment they can receive. If the patient is eligible for surgery, very limited of the patient in our practice, we can see around 5 to 10% patient can be candidate for some surgical intervention. That is only for T1 and T2 TCs. But majority of the patient we treat with the chemoradiation, and after that, based on the response, we need to treat with the consolidation radiation, or we can give some PCA for this patient if the patient is responding. So, but in spite of this locoregional disease, we have a very significant initial response with the chemoradiation. Majority of the patient, they actually may relapse. So only 20% of the patient, they have in the durable response. Around 75 to 80% patient, they actually may relapse after a few months of the initial therapy. So there is an unmet need of the therapy, which can give a consolidation treatment for this category of the patient also. And if you see the 5-year outcome of OS of this limited stage is around 16 to 34%. So still we have the limited outcome and the median OS of 25 to 32 months for the limited stage of the patient. So this is the advancement in the limited stage. So we have a split in etoposide 1985, and the radiation, the data is since we are using 1992 and 1999 we have the radiation and the PCA has been added, and since 2002 we have the chemoradiation which is there, and the concurrent chemoradiation is superior with the sequential chemoradiation, and that still is gold standard till now that we are using till now. If you see the current update in the NCC in 2025, currently for this category of the patient, the chemoradiation is the gold standard, and those patients who achieve a complete or partial response, we can give this adjuvant therapy, and now we have the durvalumab has been approved as a adjuvant therapy, and the PCI which was there for those patients which is having response, and we are using for this category of the patient, but currently, we have recently US FDA is approved as a durvalumab as adjuvant therapy for those patients who achieve complete or partial response after the limited stage of the chemoradiation therapy. So this is the summary of the standard of care of small cell lung cancer for limited stage. We have chemoradiation is a curative treatment, but we need to have some more agent as we have a data of adjuvant durvalumab. So currently we are using the platinum etoposide plus radiation. That is usually 4 cycles and 1 or 2 cycles we combine with the chemotherapy with radiation. And concurrent chemoradiation is standard of care. PCI is recommended for eligible patient to prevent the brain metastasis. While extent stage, which is more aggressive disease, and majority of the patient we see in this stage only, and where we need to combine immunotherapy with the platinum etoposide, and we have a 2 immuno-oncology agent, that is durvalumab and atezolizumab, which are using in our practice, which is the preferred agents. And this is the first line therapy, and which gives the highest OS survival, approximately 12 to 12.5 months we're getting for the combination of immuno-oncology with the chemotherapy agents. And those patients who are the responders, we can still give the brain radiation as a PCI, or in some patients we give the thoracic radiation. In spite of that, there are a lot of patients who going to relapse a short period of time, and we need to treat the second line therapy based on the duration of the response. With this, I thanks to the organizers and over to the sponsor. Thank you.
Thank you, sir. Moving on to our next speaker.
Should I share my slide?
Yes, sir. Our next speaker is Dr. Trinanjan Basu, Senior Consultant and Head, Department of Radiation Oncology. Over to you, sir.
Yeah. The slides are visible, right?
Yes, sir.
Thank you to AstraZeneca for the kind invitation. So, Dr. Ashish has set the stage of the overview of small cell lung cancer. So, I'll be concentrating on what's the role of radiotherapy in small cell lung cancer. Uh, yeah, so in disclosure, non-financial, but there is some data and presentation kindly provided by AstraZeneca, and I have few of my additions. So the small cell pre-immuno era was considered to be a very chemo-radiosensitive disease, but a very pathetic disease in terms of recurrence. People used to respond and relapse in a very short time. So you can see from the graph, and on not only the relapse used to be thoracic, there used to be a lot of CNS recurrence as well, which is quite high. That's a reason PCI became a part of treatment in the radiation protocol. This is how it has evolved. We have already heard a long back, 3 decades back, from very simple chemotherapy to adding radiation with chemotherapy and PCI. From a radiation perspective, an important thing like convert trial will come to that, and till the era of immunotherapy. Since we heard this, so a small cell is a disease where besides the TNM, the more common is the Veteran Administration Lung Study Group, disease of limited and extensive. The very rare of very limited disease we hardly see in India in any of our practice, which has a role of surgery, but that's very rare to see. Even limited is rare for us. Most of our disease are extensive. It's simple. Limited is limited to lung and the node on the ipsilateral, and the moment it goes out of it, it becomes extensive. So, what's the role of radiation in small cell lung? So, I will touch upon the ASCO and ASTRO guideline. Basically, the first, the ASTRO endorsed guideline, and then ASCO also endorsed it in 21. The role in limited stage, the role in extensive stage, what dose, what fractionation, how the techniques, and what the timing. What's the role of PCI as of now? And is there any role of SBRT akin to NSCLC in SCLC? So the long back, the meta-analysis has showed that combined therapy improves the survival, and no doubt in that. Just a minute. So that's how the treatments are. And even a meta-analysis in 2016 has showed that once the limited stage are planned for radical CTRT, the radiation should start latest by, if possible, with beginning, or if not, by the second cycle of chemo. And it has an advantage in survival from the meta-analysis reported. So the evidence from stage 1 to 3, we know that CTRT scores over chemo, early initiation or combination of radiation scores over the late initiation from a lot of studies and the Cochrane review, and concurrent scores over sequential. Now, then we have a long back intergroup data, which has shown and tried to do a twice daily, something called hyperfractionations versus once daily radiation, and twice daily significantly improved the 5 years overall survival rate. However, it also added to grade 3 radiation esophagitis, which was significant. Now, there's a logistic challenge to it, and reason small cells is one of the disease where hyperfractionation, which is a low dose but given twice a day, has been proven long back across studies that it has benefit, but it's not able to see in a practice setting. More pragmatic and contemporary would be Convert, which has reported both 2 and 5 years overall survival between once daily and twice daily. So the OS eventually did not differ between once daily and twice daily. With both the regimens, the reported results, whether you do a once daily, which most of us end up doing once we get limited, or twice daily, the results are similar, and even the reports are better than the intergroup study. Even the toxicity were kind of similar. But one important premise of Convert was they tried to show a superiority of once daily RT compared to twice daily, when which is not proven. So, if possible and logistics permits, hyperfractionation remains a chosen standard of care in radiation force limited stage. However, most of us end up doing once daily only. The similar protocol of CalGB Alliance, which what they tried to even escalate the dose further to 70 gray. And unfortunately, their trial showed there is no much benefit of escalating the dose beyond what 60 we are doing. For lung, this is akin to the RTOG 0631 for the NSLC. There is no additional survival benefit by doing it. And there are some phase 2 trials also going on of standard VAS versus high dose, and we'll only see the results once they are published. So these are the key trials which have addressed radiation regimes, starting from the intergroup to convert to the CalGB and some Chinese data as well. And more or less, you can see the hazards are equal in either of the protocol. Some difference in the acute toxicity, which would be a bit more in the hyperfractionation arm. So we know until the initial after time, the best survival results are achieved if possible by doing early initiation and twice daily, which is hyperfractionation, over concurrent CTRT. Now, what happens with PCI? The ones who are achieving complete remission, PCI gives a benefit. The benefit stays even in 3 years. There's a clear-cut absolute improvement in the control, both intracranial and as well as overall. The standard dose versus higher dose after completion also have incorporated, and there is really no significant reduction in the total incidence of brain mets observed after higher dose PCI. So as of now, after the chemoradiation, once we do PCI, 25 grain 10 fractions, which is 2.5 gray per fraction, which remains the standard of care for limited stage small cell. So the current evidence at 3 years after the Oprin meta-analysis, there's a 6% absolute benefit in survival. And these are the other trials counting the very recent ASCO ones, Adriatic, which are evaluating the different combinations of with the immune era and chemoradiation, and also some permits even PCI. What's the role of PCI in an MRI-based surveillance? So the data is kind of divided between different trials. Those in especially the geriatric population not opting for PCI, they requires a lot of MRI-based surveillance, and we all know how the compliance becomes a concern in that. Now coming to what's the role in extensive stage small cell. The CREST trial design started doing after the initial platinum-based chemo, randomized between a thoracic radiation of simple 30 grade 10 fraction, add PCI versus don't add, and they tend to show a 1 year survival benefit. And with the incorporation of recent immunotherapy trial, lot of low dose radiation for the extensive cell are underway as well. The PCI in extensive stage after the initial response is the data is bit divided between the URTC and the Japanese study. One showed improvement, one showed no difference between doing and not doing PCI. So what Astro endorses? Let's see some different cohort of SCLC, which we don't see. Is there a role of SBRT in SCLC akin to NSCLC? So if we really get to see a stage 1, stage 2 small cell lung cancer, both ASCO and Astro endorses doing it, but unfortunately, we hardly see that. If we get to do for a stage 1, stage 2 node negative small cell, SBRT akin to NSCLC, the other parameters like peripheral, central, and ultracentral remain same as would be in NSCLC. What's the role of PCI in current standard when if we have these immune therapy agents? So the IMpower and Caspian data is bit divided. IMpower had no thoracic RT, whereas Caspian allowed PCI. So they're mature results, and there's something, a Raptor trial, Energy Lung 007, which added a radiation to the IO as well. So we'll have to wait for their results to know what they are benefiting. So there is some dilemma related to for good response cohort of PCI in the MR and immune therapy based era. So even for SCLC, like in NSCLC, we're trying doing this hippocampal sparing, and there are several trials looking out to it that how better the neurocognitive function in QL can be preserved in this cohort of patients. So thank you.
Thank you, sir. Moving on to our next international speaker, Dr. Noemi Reguart, consultant oncologist at the Department of Medical Oncology, Hospital Clinic, Barcelona. Over to you, ma'am.
Thank you so much. Let me share my slide. Are you seeing it now?
Yes, ma'am, it is visible, ma'am.
Okay, that's great. So sorry for the confusion before. And it's so great to be here. I will start again. And it's a pleasure, really, it's a pleasure to share with you the novel advances and breakthroughs on immunotherapy, specifically in limited stage small cell lung cancer. And I introduced myself before, but my name is Noemi Reguart, and I'm based in Barcelona, Spain. Here are my declarations of interest. And I'll go fast because it has been very nicely summarized by my colleagues, so I don't want to repeat myself, but the reality is what they said before. The evolution of therapies in limited stage small cell lung cancer have largely been unchanged for the last 3 decades. I think, as it was mentioned, most of the advances have been focused on the introduction of concurrent hyperfractionated radiotherapy, PCI. Then with the CONVERT trial, the use of one daily radiotherapy schedules being considered as reasonable alternative to hyperfractionated doses. But the reality is that we were in need of advances also in the systemic treatments, because the reality is that the cornerstone treatment of systemic treatment has remained platinum etoposide since the 70s. And it was also mentioned before, and just to focus on the importance when we are talking about limited stage small cell lung cancer, we don't want to palliate patients, we want to cure patients. And till now, with all the data we have with radiotherapy, concurrent chemoradiation, PCI, the reality is that most patients relapse within the 2 first years of disease, and at 5 years, only 1/3 of the patients are alive. So we needed to raise this bar and to get more patients that had longer survival outcomes, these patients that can be cured forever. And also, this has been nicely overviewed. Just to say that concurrent chemoradiation in current guidelines, at least in the ESMO guidelines, were the same. Concurrent chemoradiation with or without PCI is the cornerstone of treatment. Preferred chemotherapy regimens is cisplatin. Both radiotherapy schedules, once daily or twice daily, are endorsed. And as post-treatment management, ESMO guidelines endorse strongly the use of PCI in patients with limited stage small cell lung cancer, whereas in the NCCN guidelines also as an alternative suggest the option of using MRA imaging surveillance. We will talk about this later. But I wanted to put this patient of mine, because I think when we are talking about small cell lung cancer in limited stage, one thing is what guidelines recommend, and other very different thing is the reality, the clinical practice, the everyday clinical practice. Because the reality is that we have to take into consideration multiple patient-related factors. And this is because patients can be elderly, can have impaired COG performance status. We know that patients with small cell lung cancer normally at diagnosis have a lot of burden of symptoms and disease. And then we have to keep in mind that sometimes we have problems with the feasibility and logistical challenges for radiation delivery. And although we like to start concurrent chemoradiation as soon as possible at second cycle, sometimes we cannot do that because the patient needs some feed. Sometimes we have patients that develop toxicities due to the radiotherapy or concurrent chemoradiation that preclude the premature cessation of the treatment. We have local relapse in those patients, in the majority of the patients at the first 2 years of disease, and then we have the pneumonitis. That this is something very common when we are treating patients with radiation in the lung. This is complex, and we have to handle this in the everyday clinical practice. But one thing is very important, and it's that these patients with small cell lung cancer, multidisciplinary approach is necessary, because it's medical oncology, radiation oncology, surgeon sometimes. So we need all the multidisciplinary representation in there. It's very important to do an appropriate staging and diagnosis, and for sure, it's very important to start treatment as soon as possible. It has been said before, immunotherapies for the first time were a breakthrough, improved outcomes in patients with extensive disease, small cell lung cancer. Checkpoint inhibitors, atezolizumab, durvalumab, demonstrated an improvement in progression-free survival and overall survival in our patients, but more recently, other new immunotherapies such as tarlatamab, which is a DLL3 BiTE, also have demonstrated to be effective in patients with relapsed extensive disease, small cell lung cancer, and indeed, recently it has been approved by the FDA. So with all this data, with all these positive outcomes for patients with extensive small cell lung cancer, this leads to the hope that the addition of immunotherapy maybe it could also beneficial in patients with limited stage small cell lung cancer. And the first trial that explored this strategy, the strategy of moving immunotherapy with checkpoint inhibitors earlier into limited stage small cell lung cancer, was the STIMULI trial. This was a small phase 2 randomized trial that randomized patients to receive nivolumab, ipilimumab per 4 cycles, or continues by nivolumab up to 1 year in patients that had previously received concurrent chemoradiation and PCI. This trial had to face a lot of challenges because there was a premature closure due to slow accrual. But as you can see here, the curves were exactly the same. Indeed, the outcomes at 2 years were 60% in both arms. So the trial could not demonstrate that consolidation immunotherapy could improve outcomes in patients with limited stage small cell lung cancer. And there were concerns because there was a worse tolerability. Indeed, grade 3 adverse events were observed in 2/3 of the patients, which is a high rate of adverse events, and treatment discontinuations were observed in 50% of the patients. Nonetheless, immunotherapy has remained a promising area of investigation, and despite these initial negative results of the STIMULI trial, there have been other pivotal phase 3 trials that have that aim to explore the use of immunotherapy, building on this radiotherapy, concurrent chemoradiotherapy backbone. And these trials have phase 3 trials have explored 2 different strategies. One strategy is giving the immunotherapy as consolidation. That means patients treated with chemoradiation, concurrent chemoradiation with or without PCI, and then a consolidation phase with immunotherapy. Whereas other phase 3 trials have explored to introduce immunotherapy at an earlier phase, that is, givenly concurrently with the chemoradiation. And for sure, the first landmark phase 3 study with results has been the Adriatic trial. And this is an important trial because it's the first phase 3 study that has addressed the critical question of whether the addition of immunotherapy, this case in the consolidation phase after concurrent chemoradiation, could improve survival and the durability of responses beyond those that were observed with the standard of care of concurrent chemoradiation. And let's have a look more specifically on the details of the study design. The Adriatic is a randomized, double-blind, placebo-controlled, multi-center international study. And the trial included patients with limited stage 1 to 3 small cell lung cancer. Patients had to have a ECOG performance status 0 or 1, and all patients had been treated previously with concurrent chemoradiation and demonstrated that there was not progression after this treatment. PCI was permitted, but was not mandatory. A total of 730 patients were randomized to receive durvalumab, placebo, and a third arm with durvalumab and tremelimumab. The concurrent chemoradiation components were permitted as per standard of care of the center. Both platinum, carboplatin, and cisplatin were permitted. Also, both radiotherapy schedules, once daily or twice daily at the standard dose, were also permitted. But one important criteria, inclusion criteria, is that radiotherapy must be initiated no later than the second cycle of chemotherapy. Another important criteria is that the randomization or the initiation of consolidation durvalumab after concurrent chemoradiation could be started immediately up to 42 days. That means 6 weeks after the ending of the concurrent chemoradiation and the PCI. That was important inclusion criteria. Patients were stratified according to disease stage and the use of PCI, and the primary endpoints of the trial were overall survival and progression-free survival. The trial, the first results of the trial, the interim analysis, they have been presented for the first arm, durvalumab compared to placebo, whereas the third arm, which is durvalumab and tremelimumab, remains blinded. Here, the baseline characteristic of the patients, overall, the characteristics based on the clinical factors and as well as the different treatment patterns, as you can see, were well balanced between both treatment arms. The median age of the patients was 62 years old, which is a bit younger than what we are used to seeing in clinical practice. The majority of patients were male. There was a equal representation of Asian and non-Asian patients. And as I said before, they were permitted to use different, as per local practice, different concurrent chemoradiation regimens that were broadly represented, and this is very important in the Adriatic trial. Most patients were treated with carboplatin, with cisplatin, 2/3 of the patients. The majority of the patients received one daily radiotherapy. We can talk about this later. 2/3 of the patients received one daily radiotherapy, and half of the patients, 50-50, were treated with PCA radiation therapy. Approximately 1/3 of the patients completed the maximum of 2 years of consolidation treatment allowed with durvalumab, but among the causes of diseases discontinuation, the most common cause was disease progression. And here the results of the trial. The trial met both primary endpoints with a median duration follow-up of 37 months and data maturity of nearby 50%. Treatment with durvalumab allowed for a significant and meaningful improvement in overall survival for over 2 years. That's a lot if we take in mind other clinical trials. Median overall survival was 33 months with placebo and 56 months with durvalumab with a hazard ratio of 0.73. And at 3 years of treatment, 47% of patients with placebo were alive compared to 50-60% of the patients treated with durvalumab. One important thing I want to draw your attention is the median overall survival in the placebo arm. It has been mentioned before, this 33 months exceeds a bit what it was reported in the CONVERT trial, which established a median benchmark of 25-30 months with the use of once daily or twice daily radiotherapy. But just keep in mind that the inclusion criteria of this trial was a bit more restrictive than the CONVERT trial, and it's important to remember that in the Adriatic trial, patients were randomized after concurrent chemoradiation, and those patients that had or progression of disease were excluded of the trial. So it was more restrictive population of patients. The trial also met its secondary endpoint. After 2 years, 46% of patients treated with durvalumab stayed in remission without disease relapse, compared to the 34% in the placebo group. You see there the median overall survival, 9% in the placebo group versus 16.6% with durvalumab with a hazard ratio of 0.76. One important thing when you look at the curve is that the curve separate early and seems to widen up to 2 years, and then they seem to plateau. And this is very important because reinforce the strategy used in the Adriatic trial of using 2 years of durvalumab consolidation. One interesting thing about the results we have seen now is that the magnitude of benefit we are seeing now with 2 years improvement in overall survival in patients with limited stage small cell lung cancer differs sharply with the 2-month improvement. It has been mentioned before that it was observed in the Caspian trial, in which in patients with extensive disease, treatment with durvalumab in combination with chemotherapy only provides a significant but modest 2-month median overall survival improvement. But on the other hand, this is very consistent what we have seen in other settings with other settings in non-small cell lung cancer in patients with locally advanced disease, in which an 5 years update of the Pacific trial demonstrated an 18-month improvement in overall survival. And it's not clear why we are seeing this difference between patients with potential curative intent, such as limited stage small cell lung cancer or locally advanced non-small cell lung cancer, compared to extensive disease. There might be reasons, underlying reasons, such as this is a more immunocompetent host because the patients are at the early stage, or maybe it's because the immunotherapy has a higher ability to target this micrometastatic disease, or maybe it's because we are giving radiotherapy before the treatment, and that can induce a synergistic immunogenic effect. Whatever the underlying reason explain these observations, the reality is that the early we detect, the early we treat, the better the outcomes in both small cell lung cancer and non-small cell lung cancer. Overall survival also favored durvalumab in all pre-specified subgroups that were analyzed according to the different clinical characteristics, as well as the different treatment patterns with regards concurrent chemoradiation. And one interesting observation here is, as you can see here, it has been highlighted in pink, is that those patients that started durvalumab earlier, that means before 14 days, seem to derive higher benefit from durvalumab than those patients that start after 4 weeks of treatment. And this is an observation that indeed was similarly observed in the Pacific trial. However, this data must be taken carefully because the trial was not powered for subgroup comparisons, and the data must be biased because those might only reflect a more fitter and selected patient population. But I think it's therefore reasonable to start as soon as possible with finished concurrent chemoradiation with durvalumab. However, I think in those patients that are not fit enough because they have toxicities or they have side effects, it's also reasonable to start later and allow these patients to recover from previous concurrent chemo radiation. Another important question was to examine what were the overall clinical outcomes according to the different treatment patterns that were used as per standard of care. And those were very nicely represented in the Adriatic trial because we had patients treated with both carboplatin, cisplatin, once daily, twice daily, and patients treated with PCI and others without PCI. And as you can see in the course, those patients treated with bi-daily radiotherapy, hyperfractionated doses, seem to derive higher benefit or higher outcomes in both arms, in the placebo arm as well as in the durvalumab arm, compared to the patients treated with once daily radiotherapy. And on the other hand, very interesting observation, those patients that were treated with carboplatin seem to derive higher benefit from the combination with the treatment with durvalumab compared to those patients treated with cisplatin. Again, careful, the study was not powered for this comparison, but However, these results reinforce that whatever the treatment strategy we're using with concurrent chemoradiation reinforce that we are going to see benefits from giving durvalumab to our patients. Another important question was PCI. Half of the patients in the Adriatic trial, 50% received PCI. And this is very important. It has been very nicely overviewed before by our colleague, but we know that PCI reduced the incidence of brain metastases by approximately 20% in patients with limited stage small cell lung cancer. However, there are some concerns in the benefit in overall survival because all these trials that confirm the use of PCI were done in the era before immunotherapy was introduced and when MRI imaging was not a standard of care for the patients. So it was very interesting also to see whether these patients in the Adriatic trial had different survival according to the use of PCI. And as seen in the curves, patients that receive PCI seem to derive higher benefit in both arms, in the durvalumab arm as well as in the placebo arm, as compared to those patients that did not receive PCI. But we need prospective data. That it was only a subgroup analysis, and we need prospective data that confirm the use of PCI in the era of immunotherapy. And those are two important trials that are going to, I hope, answer this question. This is the PrimaLung trial and the Maverick trial that are going to explore which is the role of PCI in the new era of immunotherapy, in the new era of MRI imaging in both patients with limited stage small cell lung cancer and extensive stage small cell lung cancer. Another very important question of the Adriatic trial was the safety, and that was very important because we have to keep in mind that these patients had been, before receiving consolidation with durvalumab, had been treated with concurrent chemoradiation. So there were concerns that the treatment with durvalumab maybe could induce a higher rate of toxicity. But the results is that the reality is that the tolerability of durvalumab was impressive. The maximum grade 3-4 adverse events were exactly the same in patients treated with durvalumab and those patients treated with placebo and were 24%. And the rates of treatment discontinuation were low, 60% with durvalumab and 10% within the placebo arm. And as expected, the most common side effects were radiation pneumonitis, which is what we are used to seeing patients treated with standard concurrent chemoradiation, and pneumonitis. You can see that the side events were distributed equally in patients treated with the exploratory arm with durvalumab and the patients treated with the placebo arm. And most events were manageable. Most grade 3 or higher adverse events were manageable and again well distributed across both arms. As expected, the grade 3-4 treatment adverse events were more common in patients treated with PCI, in those patients treated with chemotherapy, and the differences between those patients treated with one daily radiotherapy and twice daily radiotherapy were not the magnitude of difference was not as were not seen between both arms. And the treatment adverse events leading to treatment discontinuation were very similar across both groups. Another important thing is radiation pneumonitis, and this is very important because radiation pneumonitis is common in clinical practice. We see it in patients with limited stage small cell lung cancer as well as in patients with locally advanced non-small cell lung cancer treated with radiation into the lung, and in some cases can impair quality of life and require corticoid treatment. And there was a lot of interest to know which were the features of pneumonitis in the Adriatic trial and how were these pneumonitis addressed in the trial. And here the rates of pneumonitis, both radiation pneumonitis and pneumonitis seen in the Adriatic trial. Overall, any grade of pneumonitis in the trial were exactly or more or less the same in both arms, 38% in the durvalumab arm and 30% in the placebo arm, any grade. But the important message is here is that the maximum grade 3 or 4 pneumonitis was less than 3% in each arm, 3% with durvalumab, 2.6% with the placebo arm, which reinforce that the use of consolidation durvalumab doesn't increase the risk of developing grade 3 or higher pneumonitis. Indeed, these grade 3 pneumonitis were very consistent with the grade 3 observed in other important trials, the CONVERT trial, 2% with a once daily or twice daily radiotherapy, and in the Pacific trial in non-small cell lung cancer, also using radiation in the lung, 3% of grade 3/4 pneumonitis. Again, important. In the Adriatic trial focused on a highly selective population. It's not exactly the same when we are comparing rates, the patients included in the Adriatic trial or the patients included in the CONVERT trial, because patients included in the Adriatic trial, those that had a grade 2 or higher pneumonitis after concurrent chemoradiation were excluded from the trial, and there were very strict criteria in terms of radiation fields. Baseline characteristics and prior treatment patterns were homogeneously distributed in patients who developed pneumonitis and those patients who did not develop pneumonitis. There were no difference according to clinical characteristics, treatment patterns. The only difference it was notable was that there was a higher incidence of radiation pneumonitis in patients from Asian origin. Regarding the onset and resolution of pneumonitis, the median time of onset of the pneumonitis was similar for both arms, patients treated with durvalumab and placebo, and it was 56 days median time of onset, and indeed, time to resolution was a bit lower for those patients treated with durvalumab compared to patients treated with a placebo, with median time to resolution of 59 days with durvalumab and 96 days in patients treated with placebo. However, probably because of the concerns of physicians' concerns regarding the use of an immunotherapy after concurrent chemoradiation, the number of patients that require corticosteroid treatment was higher in the group of patients treated with durvalumab compared to the patients treated with placebo, and also probably because of the concerns of the physicians, the number of treatment discontinuations were also higher in patients treated with durvalumab than patients treated with placebo. And one important thing that it hasn't been answered, and I hope to see further results from the trial, is whether the benefit of durvalumab in these patients that had to stop the treatment or discontinue the treatment due to pneumonitis, if the benefit of durvalumab is still maintained. And this is important because it could provide valuable insights into how do we have to optimize the definitive chemoradiation while ensuring the compliance of consolidative durvalumab. So this is something that probably future data on the Adriatic trial will provide more insights on this topic. And very important, and lastly, very important is the quality of life of the patients, because durvalumab demonstrates that preserves the patient-reported outcomes for symptoms, and its benefits outweigh the risk of side effects. Indeed, as you can see here, mean changes from patient-reported outcomes subscale from baseline were small, and improvement rates were indeed reported in both arms across most subscales. But we have several challenges when we are facing with this disease. It has been said before, we don't have biomarkers, we have all the small cell lung cancer classification based on these transcriptional subtypes. However, it has not, these transcriptional subtypes have not been able to be identified as the biomarkers for immunotherapy selection, and neither TMB or PD-L1 or inflammatory subtypes. So also it will be very important to see the future data on exploratory biomarker analysis from the Adriatic trial to see if some or one of those biomarkers can provide any sign to select patients with a small cell lung cancer in an earlier stage disease. Another important question that is not answered by the Adriatic trial, and we need further information, is how do we have to approach in those patients that do not meet the criteria for the Adriatic trial, of those patients that are not suitable to receive the concurrent chemoradiation. And this is important because approximately 10% of the patients are not going to be candidates to receive concurrent chemoradiation and will have to receive sequential treatment. So we need real world data, and this is very important to have specific clinical trials in this specific patient population. And this has been addressed in locally advanced non-small cell lung cancer. For example, we have the results of the Pacific 5 trial that demonstrate that those patients that are treated with sequential chemoradiation attain the same magnitude of benefit that patients that receive concurrent chemoradiation. And we don't have a pivotal trial in limited stage small cell lung cancer. I would like to see an Adriatic 2 trial exploring specifically this group of patients, but we have some academic trials that are exploring this specific subgroup of patients, frail patients, that are not candidates for the Adriatic criteria, to see if durvalumab offers the same magnitude of benefit in this specific subgroup of patients. Another important question is whether the timing of immunotherapy matters. That means we have in the Adriatic trial, immunotherapy is given as consolidation, but other pivotal trials are exploring whether immunotherapy can provide further higher benefit if administered earlier concurrently with chemoradiation. And we do have the results of one of the trials, an NRG trial, which explored the use of atezolizumab given concurrently with chemoradiation at the beginning, and then with the consolidation phase after this concurrent chemoradiation treatment. One very important difference with the Adriatic trial is that in this trial, the randomization occurred before treating the patients with concurrent chemoradiation. So in here, we cannot exclude those patients that progress under a chemoradiotherapy. And also, another important difference is that the consolidation phase was for 1 year instead of 2 years of the Adriatic trial. This trial was presented this year, the results, negative trial, no differences between the both arms. So that brings us of a lot of questions. Why immunotherapy does not benefit if given concurrently with chemoradiation. And this indeed has been seen also in non-small cell lung cancer. We have the results of the Pacific 2 trial that explore this dissimilar approach in locally advanced disease and were also negative. And we don't know why this immunotherapy given with the radiation might decrease the effect of immunotherapy. So, well, we have 2 other trials, pivotal trials ongoing. It'll be very interesting to see if these results are reproduced or how they can show different results with the use of concurrent chemoradiation. And I'm finishing now Just saying that there are other strategies that are being explored in important phase 3 trials. Those are big different strategies exploring novel components, novel immunotherapies such as tarlatamab, a DLL3 BiTE antibody that is being explored in the phase 3 Delphi 306 trial. Tarlatamab is given for 1 year as consolidation after concurrent chemoradiation, and other trials such as the Artemis trials, Artemis 009 is exploring another more, I would say, innovative approach, that is the use of an ADC after as consolidation strategy after concurrent chemoradiation. These trials are ongoing right now, and they will give a lot of insights on what's the optimal duration treatment, how will safety impact quality of life, and this is very important, specifically when we are thinking about ADCs, and also the implications of a suboptimal or control arm, because right now we should be using durvalumab, and in these both trials they are using placebo as the control arm. And this is my last slide and brings me to the end of my presentation. Adriatic represents the first practice-changing study in decades and the first immunotherapy trial in limited stage small cell lung cancer, and confirms consolidation durvalumab as a new standard of care for patients without progression to concurrent chemoradiation with or without PCI, regardless of the treatment components, with a very favorable risk-benefit profile. There are challenges and ongoing research. We will need to see how's the follow-up on the Adriatic and other pivotal trials to define which is the optimal sequencing of immunotherapy and the role of novel therapies in this limited stage small cell lung cancer. Very, very important, addressing high-risk subgroups that are ineligible for concurrent chemoradiation or do not meet the Adriatic criteria. We need to clarify which is the role of PCI in this new era of immunotherapy, and for sure we need to advance in personalized and biomarker-driven approaches. And that's all, and thank you so much for your attention.
Thank you, ma'am. Now I request Dr. Vinod Raina to give comment on Dr. Noemi talk, and also requesting all panelists to feel free to ask questions on Dr. Naomi's talk.
Hello, can you hear me?
Yes, sir.
I thought we were going to have the panel discussion now.
Okay,
Hello.
sir, we can go ahead with the panel discussion, sir.
Well, what has been presented is a very interesting data and very novel data for limited stage small cell lung cancer. Unfortunately, the problem is we don't see too many limited stage small cell lung cancers. Most of them are advanced stage. So that I think it comprises only 20% of all small cell lung cancers we see. But anyway, it's a very useful data and a very innovative trial in limited stage small cell lung cancer. So let's go for the panel discussion now.
Thank you, sir. Moving on to a case-based panel discussion, our moderator is Dr. Biswas, Senior Consultant, Medical Oncologist. Over to you, sir.
Thank you. Good evening, sir. Dr. Raina.
Oh, hello. How are you?
Hello, sir. I'm fine, sir. Good to see you, sir. And good evening, Dr. Noemi. It is an excellent deliberation and a lot of insight, subgroup analysis, detailed discussion on the Adriatic study. And it's a lot to learn from you. So I welcome all of you for this today's webinar. I would like to call my panelists also. Dr. Sachin, are you there?
Yeah, can you hear me? Or
Hi,
can you
I
see
can
me?
hear. Yes, I can hear you. Good evening. Madam Dr. Jyoti, are you there?
Dr. Jyoti is not logged in yet, sir.
Okay, right. Dr. Charu, I can see you. Good evening, ma'am.
Good evening.
Dr. Sachin Khurana. Sachin, I can see Sachin's name is muted.
Yes, sir. Hi, sir.
Yeah, hi, good evening, Sachin. And again, good evening, Dr. Noemi. So I'll just share my slide deck. Give me some. I hope this is visible.
Not yet, sir. So it is visible now.
Yeah, thank you. So I think I will go and I'm going directly to the case-based discussion and we'll discuss all the details about durvalumab for consultation. So this case was provided me by the organizer, just a hypothetical case. So let's see. Patient, this is a case 1, 68-year-old housewife, chronic smoker, 30 pack year history, ECOG 1, no family history of cancer, presented history of cough for 2 months, evaluated in March 2024, chest CT 3 into 3.3 into 2.7, mass in the right upper lobe with mediastinal lymphadenopathy, station 7, CT abdomen, MRI brain, bone scan, no metastasis, bronchoscopy, no intrabronchial suspicious lesion. Okay, let's move. So this is the PET CT, this is the mass, and this is the mediastinal node. This is the bronchoscopy. Okay, let's move on. Okay. So the question is this, you have the history, you have the imaging, no intrabronchial mass. So question is, which investigation you do further do to confirm the diagnosis, and what do you do for a upfront MRI for all patients? So I'll start with Dr. Charu. Dr. Charu, what is your practice? How do you work up this
So,
type of patient? Yeah, ma'am.
so I think we have already done the PET CT.
Yes.
So that is done. And MRI brain, yes, for all the patients. And of course, we need the biopsy. And
So yeah,
yeah,
how do
I
you
mean,
want to get the biopsy here? This is the imaging.
so I think, we will have to get a CT guided biopsy only. It cannot be an bronchoscopic guided biopsy. So it has to
And
be a CT guided biopsy.
right. Okay. So do you just a follow-up question? Do you send any biomarker at same time, or you wait for the histology?
No, we wait for the histology.
Right, right,
And
right.
also at times, being in India, we know that there is a lot of inflammatory diseases which are there.
Mm,
So at times you also get an EBUS done just
Mhm.
to, prove the notes.
right, right. Do you send any TB PCR upfront, depending on symptoms sometimes, or
Sorry?
TB PCR for any during the biopsy for any patient?
No, no, not upfront.
Okay,
And
not
the other
upfront.
thing is, I would really like to get a PFT also done for this patient. Since she has been a smoker.
Lung function test.
Yeah, yeah.
Okay,
The
okay.
pulmonary
Thank
function
you.
test.
Dr. Sachin Trivedi, sir, any difference in opinion or any different in approach for this
No,
patient?
no. So I think I mostly agree with Dr. Charu, and we do need to rule out other inflammatory conditions, especially in our setup. We don't want to be caught off guard because we just can't take a radiological evidence to say that it is a malignancy, because the implications are huge. The second thing what I wanted to point out was in our institute, depending on the initial histopathology, there's a reflex either IHC,
Yes.
those kind of things. So most of the large hospitals have that thing. So if it is confirmed as malignancy, a reflex IHC would follow.
Right, right. So molecular testing you also do follow up only, not as a reflex testing during the initial biopsy, right?
So molecular testing, yeah, that ideally, I would want it to be, a reflex, but in the current scenario, because there's a plethora of, the type of
Type
panels.
of, yeah, we'll come to that. Yeah, right. So go for hotspot or NGS or sequential testing, right? Dr. Sachin Khuna, Sachin, are you there, right?
Yes, sir.
Sachin, would you want to go first EBUS for this patient, because this lung lesion in the middle, if you can get the
Yeah,
diagnosis from EBUS, yeah.
with with city guided biopsy, the chances of pneumothorax will be a little more in this case. So if
Yeah.
it is accessible by bronchoscopy, then I think the mass is like can be accessed by bronchoscopy also. So if
This station
sufficient.
7 lymph node.
Yeah. So it's a station 7. It's a subcarinal node.
Yeah.
So I think bronchoscopy can help to get a diagnosis with less complication. This is what I feel.
Yeah.
But obviously, the pulmonologist has to see whether he can get adequate tissue for testing. Yeah.
Yeah, I also think this subcarinal node is a big node. It can be easily accessed with bronchoscopy fast. So for this patient, I'll wait till the EBUS, because this is just in the middle. You have to traverse a lot of way to go to this small 3 centimeter lung nodule, just middle in the lung. Dr. Jyoti, any input, ma'am? Whatever you discussed for during the initial workup? Jyoti is not there, right? And we are doing a MRI brain for all upfront patient, are we, Sachin? Or is your practice?
Some form of brain imaging is required. If it's PET CCT, then and CCT is not showing any mets, I may skip MRI, but usually MRI for all the patients. Yeah. So some kind of brain imaging, either CCT or MRI, preferably MRI.
So let's say you are doing like all patient, we are doing contrast PET CT, and if the CT doesn't show anything, will you go for MRI in your practice, Sachin?
No, I would if it's a good CCT, I think I will skip MRI until unless there are any symptoms which I can, if CCT is not showing any brain met symptoms, will not be there. So I would suffice. I would stay with.
Okay, right. Dr. Noemi, your input about the MRI brain.
Yeah, for sure. I think, I think as I said in my presentation, I think there are a lot of unknowns about PCI, right? One important thing about your case is the age. While the patient seemed to have a good performance status, but it's 68 years old, it's over there, isn't it? So PCI, according to ESMO guidelines, could be endorsed. But I think right now we have a lot of concerns about the neurocognitive side effects. And this is very important because you have seen the outcomes of patients with durvalumab. So now we are going to have more patients alive and longer survival rates. So neurocognitive effects are going to be there. So I think right now in my practice, I discuss it with patients, and I always require an MRA because I think that's key. That's key if you want to do surveillance. If not, I agree that CT is enough. But if you want to do surveillance instead of PCI, I think a CT is not enough.
Okay. So how many cases you have seen that CT is not showing any mets and you do an MRI, even for asymptomatic cases, there is a brain mets in MRI? Because we have seen in a couple of cases.
Well, I would say in my case, I don't know. I'm not sure. I could not give a ratio, but if you see the data with the trial in advances is when they are using MRA, the outcome completely, isn't it? So I guess, well, probably that depends a lot on the center, the quality of the CT, and who's doing the CT, isn't it? But I think MRA can give more detailed information and higher sensitivity than CTs if you want to do surveillance.
Yeah. Dr. Charu, what is your practice? This MRI brain you do for all patients, irrespective of PET CT?
Yes, we do.
Yes. So at our center also, I do all stages, all type of NSCLC. I do MRI, and I have seen cases where PET CT is not showing anything asymptomatic, but there are brain mets. So I think in today's time, especially in a localized cases, if you are thinking about PCI or MRI surveillance, is worthwhile to do a contrast MRI. Anyway, so this patient underwent lung biopsy, small cell lung cancer, TTF1 CG synaptopositive, Ki67 90%, T2 into M0 3A limited stage as looks. Okay, so how do you manage this patient? Yeah, I'll start with Dr. Sachin Trivedi. Dr. Sachin, what is your practice? Question one, the type of radiation, why hypo or hyperfractionation, and sequential versus concurrent.
Okay, so just one point, just going back to your previous question, I just wanted to invite a comment from our radiotherapy colleague actually. About the difference in the WBRT with limbic sparing, because the neurocognitive thing which we are worried about, mostly when I was in UK, we were all the time worried about, and then my Indian colleague used to say we were able to do the limbic sparing much frequently here. So just that, please.
So yeah, sorry, come on.
No, okay. Can I take this?
Yes.
So the thing is, I mean, hippocampal sparing in small cell is still investigational. Memantine is something which we are going ahead, but hippocampals, as we know that there is a study going on where they are comparing PCI with hippocampal sparing versus PCI alone. So I think we'll have to wait for that results. In the meantime, we do memantine, and since we know that small cell, I mean, because if you have to create a cold in the PCI, we know that around a 1 centimeter rarely gets underdosed. So it's
Yes.
just that, a thing which sort of keeps us away from doing hippocampal avoidance in small cell. Otherwise, in non-small cell and breast, wherever else we are doing whole brain, we do hippocampal sparing.
Yeah. So in PCI, definitely this hippocampal sparing is not there as of now, right?
Excellent. Okay, I'll come back to this. Sorry.
Yeah.
I was just curious about that because they picked up and anyway. So what I would do is we discuss these cases in our MDT. Yeah, and definitely for this patient, based on whatever information we've got, concurrent chemoradiotherapy is the best possible option. Now, we discussed in the previous presentation about whether to do once a day or twice a day. My standard of care was to recommend twice a day, but we ended up doing once a day.
Because of logistics.
Yeah, because of logistics. And unfortunately, that has not changed. Even though very few patients do manage to get twice a day, but the number, Dr.
Yes.
Vinod also said, is quite small. Majority of the patients would end up getting once a day concurrent chemotherapy.
Right. Anyone practicing twice a day? Dr. Sachin Khurana? I think it will be more logistically feasible, problematic at AIMS, right? Twice a day. Sachin?
Yeah, so I think it is, as of now, it's once a day. I think we haven't given twice a day. It's once a day. Usual practice is once a day. Unfortunately, we are not seeing, as Professor Anna also said, we are seeing very few patients of limited stage. Most of the patients are coming at at a higher
I
stage.
think that is throughout the country, right?
Yeah. So in our experience, I think so whatever we have given is usually a once a day type.
And second thing is, I wanted to ask that what is that sequential chemotherapy? Because in small cell, I don't think anyone do sequential chemotherapy, right?
No.
How we are, yeah.
I think this is it is not been. I don't think it was ever part of a trial either.
No, what is your practice? How do you start the radiation? How do you start the chemo?
So we start with, because of it being small cell, we actually start chemotherapy as early as possible.
Right.
And we push for concurrent radiotherapy as early as possible, if possible with first, but generally they end up having with the second one.
At least the second one, right?
Yeah.
And how many cycles you give in total? Chemotherapy? 4. So that means cycle 2, cycle 3 will be the radiation, 4 will be after the complete of radiation, right?
Yeah.
Okay. I think this is the same for everyone. Any difference?
Yeah. Even we start radiation with the first cycle. So I think until unless the disease is very large or something, we generally prefer concurrent, and we are also doing OD only and not been doing twice a day.
So in my previous institute, I used to give twice a day, and it was well tolerable. And that was most of the norm. 80% used to do twice a day. But again, in my current institute, because of logistic, we are doing once a day. I think that most of us were starting on chemotherapy and then try to start radiation as early as possible, at least with cycle 2. That was the practice. And very rarely this type of nodal disease comes. I think these are mostly heavy nodal burden. I have never seen only single stations when they are usually a bulky mediastinal node, right? Dr. Noemi, I want your comment. So what is the practice there in your area? The once or twice a day?
It's the same than yours. But I could say that, I don't know, I think I think the perfect Adriatic trial is not as common. I have this impression. I mean, a lot of time we have elderly patients, small cell lung cancer. The Adriatic trial the median age was 60 something years old. I think our median age is 70 something. So sometimes the patients have a lot of disease. So we start as soon as possible. That's for sure, chemotherapy, because this is a very chemosensitive disease. But sometimes the patients are fragile and you cannot start at cycle 2. So that would be the perfect scenario. But sometimes you have to start at cycle 3. And you do that because it's not perfect, it's not optimal, but it's better than sequentiality, no?
Right.
But if not, we do the same. We start as soon as possible together with cycle 2, and we start chemotherapy as soon as possible.
So
Yeah.
I think, Dr. Biswas, the principle is here not to wait for the start of radiotherapy to give chemotherapy. So
Yes.
are doing it by design because small cell will grow very quickly.
Yes.
Exactly.
Yes.
So
Yeah, even all the guidelines, they say start chemotherapy fast and then you can add radiation from cycle 2 very safely.
Exactly.
So you don't wait till the radiation start. I think in the Adriatic, the radiation timing was allowed as high as I think 6 weeks from the cycle 1. So
Exactly. Yeah.
So you can start with at least by cycle 3.
You mean for consolidation durvalumab?
No, the radiation.
No,
The
radiation had to be started before the end of cycle 2.
In Adriatic, I think it was
In the Adriatic, cycle 2, yeah.
cycle 3, exactly.
that is before cycle 3.
Before cycle 3, exactly. So there are
Before
some
cycle 3, exactly, yeah.
Yeah. So they allowed, and there are some patients who require more chemotherapy. They are not even fit to start radiation during cycle 2. So there are few.
Yeah, that's something important that Adriatic doesn't answer. But I think, I don't know, I should not say that in here. But I think if we have a patient that starts cycle C, could you not offer the consolidation durvalumab?
I will with this result. Yeah.
So that's why we need the real world data. So we need this information. I think it's not going to impair the efficacy of durvalumab after that, but the reality is that in the Adriatic it was before cycle 2.
Right. I think the sponsor must be thinking about this Adriatic R, like the Pacific R. Let's see. Let's wait. Okay. So let's move on. Do we have a preference between cisplatin and carboplatin? Again, so which are mostly used agent? I have sent the data that carboplatin is also equally efficacious, if not more. We also know that cisplatin is slightly better than the carboplatin, at least for the systemic effect. But I think in all practical practices, many patients, as I said, 60% get carboplatin. What is the practice for others? Dr. Charu, you can take this question.
Cisplatin. I mean, if the KFT and everything is fine,
yes,
then Cis-C2. If the patient has a problem, then of course we consider carbo.
So what will be approximate proportion in your practice, cis versus carbo?
I think it's around 70-80% it is cisplatin and just 15-20% carboplatin.
Right. Any difference in others practice? Do both Dr. Trivedi and Dr. Khurana?
So I think in my
No,
practice,
it's cisplatin only in all eligible patients, cisplatin.
my unfortunately, maybe I'm a bit outlier here. I have ended up using carboplatin more often than cisplatin. There are patients cisplatin also, but carboplatin I've just had experience that is better tolerated.
Yeah. So yes, carboplatin is better tolerated, and even our most used actually was cisplatin because the myelosuppression. Myelosuppression is much more with carbo with radiation. We have seen, and I am sure others also will agree. So cisplatin will be, if the KFT is fine, patient can tolerate the hydration and everything. I think cisplatin is mostly preferable. But anyway, there are patients who do receive carboplatin, and those patients who had toxicity switch to carboplatin from cisplatin. That is fine. So we are not endorsing that carboplatin should be as per the subgroup analysis, but yes, it can be given. That is the message should be given.
I think right now the trends with the Adriatic trials will change a bit our preference for cisplatin because seeing the data and the magnitude of benefit of durvalumab, because I think we were very supportive of cisplatin because we wanted to give this minimal benefit of cisplatin over carboplatin, but right now with compared to the magnitude of benefit of the consolidation, I think probably with time people will be more pro to give carboplatin.
Right. I think the magnitude of benefit with cisplatin over carboplatin will be traded off by the consolidation with durvalumab if someone is receiving that.
Yeah, that's something very strange of the trial that those patients treated with carbo seem to derive higher benefit from the consolidation durvalumab, but I cannot find what's the explanation for the results. So I think this subgroup analysis is not does
to be
not
taken, yeah, to be taken in a
exactly.
strong manner, right? Very important thing is the PCI. A lot of things, both from the treatment control view, the long-term toxicity, MRI surveillance, and the timing. So I'll start with Dr. Charu. Dr. Charu, what is your practice? First, the two questions. What is the proportion of patient in limited stage we are discussing receive PCI, and when do you place the PCI?
So the thing is, one is that in a limited stage, generally we are giving PCI. It's
Yes,
only the elderly, elderly
very few.
people how where we talk to them above 65. That is the age group where we sort of we at times hold back. And if already there is some neurocognitive decline,
Yeah,
you can those are the patients where we will sort of not consider giving PCI. And we would give PCI after you're finished with your chemotherapy.
yeah.
So after
So
2 weeks, 3 weeks of
at
that,
least 2 3 weeks. Yeah,
yeah,
at least 2 3
yeah,
weeks.
yeah, yeah.
Right. Dr. Trivedi, what is practice time to give PCI for all eligible?
Yeah, so everyone who is eligible for to see radiotherapy
Okay.
colleagues, and I think what we believe in our institute is to give patient a choice.
Hmm.
We recommend it, but depending on whatever, because patients are also nowadays well read and well informed.
Mm, right.
So, but I do recommend it to everyone.
So I have two follow-up question.
Mhm.
Now we know that PCI and MRI, there's some data also with MRI surveillance. So would you choose MRI surveillance for this patient if someone agree and compliant instead of giving PCI?
Well, if they are not keen to have PCI, they can choose MRI surveillance. But I know, see, MRI surveillance, even if patient who had PCI, I would want to do it in a year's time.
Absolutely.
Yeah, so that is a given in what I would do. But PCI recommended, not mandatory, but patients can choose it.
Right. Thank you.
Because some
Dr.
patients,
Yeah.
when they read about this neurocognitive,
Mm-hmm.
some people are really not keen to actually have it.
Yeah, they are skeptical. Yes, there will be patient. If there is a well compliant enough want to go for surveillance, I think few of those cases can be think of because as I discussed and Dr. Noemi also said, if you in the trial, 40 to 50% didn't receive PCI, and many of the institute are doing MRI surveillance. Uh, Dr. Sachin Khurana. Sachin,
Yes, sir.
now the issue is that in even you have seen the subgroup that if you start the durvalumab maintenance early, the result is better, just like Pacific, right?
Yeah,
Now, if we are going to give cycle 4 after completion of chemo radiation, and then wait for another 3 weeks for PCI, there will be say at least median 6 to 7 weeks gap between the last dose of radiation to durvalumab maintenance, right?
correct. Yeah.
So, do you want to skip the cycle 4 chemo and give the PCI so that you can start the early durvalumab?
I'm I'm more believer of at least completing 4 cycles of chemotherapy. I would not skip 4 cycle of chemotherapy. This is
So
for sure.
I
So
rephrase my question. By
yeah,
giving cycle for chemotherapy and PCBI, and starting the durvalumab at 8 weeks post radiation versus skipping the cycle for giving PCI and start the durvalumab early. Do you want to trade off the benefit? It's a hypothetical. Yeah, it will
I
come.
know. No, so I would definitely not skip 4th cycle. I would
Right.
give 4th cycle
So you are clear.
and then start double map. And just to clarify with other
Hmm.
panelists also
Hmm.
and your practice also, would you consider PCI even if the patient has stable disease? A patient with stable disease would progress quite early. If the patient
Yeah.
has very good partial response or CR, yes, PCI can be done in eligible patients who do not have neurocognitive abnormalities or poor PS or
As
anything.
of now, we are
But with
giving.
stable disease, would you really consider PCI? Because they will ultimately progress. Unfortunately, the stable disease patients, I haven't seen
The small cell
remaining
with
stable for a long period of time.
the small
So,
cell cancer with stable disease, I would be really worried actually.
Hmm.
Thankfully I have
As
not
Sachin
come
said.
I have not come across that because they respond well to chemo. But
Yeah.
but yeah, that's a good question.
But you have seen there are patients who within 2 months of completion of CRT develop disease progression. So there are patients who didn't respond good. Dr. Noemi, your comments on this?
Well,
Do we
this is
complete cycle
really
4?
well. This is well. I would not skip chemo.
Okay.
This is very important. Chemotherapy. This is a very chemosensitive tumor, so we cannot skip any chemo if we can, of course. And regard the timelines. Well, I think it's very important the timelines because at the end we have to, after concurrent chemoradiation, one important question: when are you performing the CT? Because that's important.
Yes.
Because if we
Yes.
want to start early, maybe if we are doing the CT after 2 weeks of finishing, maybe that's not time enough to see really the reduction of the tumor. So in one way, we want to start the consolidation as soon as possible, but that makes us to maybe restage the tumor
Cycle
earlier.
later. Yeah.
Exactly.
Right.
So I think that the durvalumab consolidation is going to change our timelines and patterns of reevaluation of the response of the tumors.
So another follow-up questions. If you are going to give PCI, it will take another 2-3 weeks after completion of radiation, and then you have to wait some more time to start the durvalumab. So what if we start the durva early and give the PCI in between cycle 1, cycle 2 of durva?
Well, that was not considered in the Adriatic
Yes,
trial.
Adriatic.
I think right now, I guess. Well, I'm based on non-small cell lung cancer, but I guess it could be more or less the same that immunotherapy in non-small cell lung cancer. So I think it could be safe. However, I think we cannot be sure of this
Yes,
because
this
that
approach.
the durvalumab had to be started after the completion of
All treatment.
PCI and concurrent chemoradiation. Yeah.
Right.
And I think the premise of giving durvalumab and PCI are very different. Durvalumab, we are sort of controlling the systemic treatment, and PCI, we're controlling the brain mets.
CNS.
So we have to just sort of weigh both the things and then take a call what sorts of presses us the most.
Absolutely. So we are giving PCI, or in few cases you may go for MRI surveillance, but PCI is required. That is the message.
I would like to, sorry, if I can ask a
Yes,
question
yes.
to Naomi. With your PCI, have you started giving memantine?
Yeah, we have.
Yeah.
Yeah, we have.
And the hippocampal sparing?
Two. Yeah.
You
We're
have
using both. We're using both, although it's not a standard of care, as you have nicely said before. But our radiation oncologist is very pro to using both, so we are using it. And I have to say, our radiation oncologist doesn't like that much follow up with MRI. So sometimes we have discussions about this, but yeah, we are using it.
Okay. Thank you.
Okay. Good. So this patient from March to August is a 4-cycle etoposide carboplatin along with 60 grays in OD fraction over 6 weeks of radiation. Post-treatment response PR, had grade 3 myelosuppression and grade 1 nausea during the treatment. I think this was the baseline. This is post-treatment, very good partial response. And August 24, station 4, session 7 was negative, right? In your opinion, do you think it is a correct approach for this patient? Would you manage differently PCI surveillance? Will you add durvalumab in this? I think we have discussed most of the patient.
I think we need to move to case 2.
Yes, sir. Yes, sir.
Case 2.
Yeah. So I think all part of this.
Can I say something about the previous case that I think it's very interesting is why do you need to rebiopsy the tumor? This is not a common approach.
No, not a practice. Not a practice. I think they have maybe done some for other reason. Anyway, we don't check it by Bivas TB. So moving quickly to case 2, 73 are again female, hypertensive, diabetic, COPD and hypothyroidism, nose to autoimmune disease, reformed smoker, 40 pack year, no family history. Okay, symptoms July 2020, dyspnea, okay, dysphagia, loss of appetite, weight loss, ECOG 2, saturation 91% in room air, respiratory 20. This is the CT image. I think lots of mediastinal node. This is the lung mass with some distant collapse must be. with a liver mets. You can see one liver mets here. Again, look like small cell because too much of bulky mediastinal node. Yeah, multi-station bilateral mediastinal node, subacral mass extend to the left lung, increases trachea and mediastinal structure, liver mets, adrenal gland mets, MI brain no metastasis, EBUS TBNA showed small cell lung cancer, ISC positive. I think investigation we have already discussed what we do for small cell, MRI brain for almost all patients in a small cell. What is your plan of management? Chemotherapy regimen in first line extensive stage small cell SCLC. So now we're moving to the extensive stage. So I'll start with Dr. Sachin Khurana. Sachin, what is your practice here, CIS or carbo?
So in extensive stage, I commonly use carboplatin uh, because in extensive stage, it's okay to use carboplatin will avoid the toxicities of cisplatin. And this patient particularly is an elderly patient. If the, I would in fact modify maybe my treatment based on her PS also,
So this
based
patient was
on her
PS2.
performance status. PS2, I would rather just start with the single agent
Single
carboplatin
agent
and see whether
carboplatin.
PS has improved or not, and then would add etoposide. In some patients, I have used etopocarbo as weekly also, and for at least for a cycle for 3 weeks, they also show good tolerance and improvement in PS, and then we move on to a 3 weekly regimen. So yeah.
Sachin, follow-up question. Any patient you have used, like, let's say with some CKD, etoposide irinotecan? Sachin Khurana? Okay, I can't. So Dr. Sachin Trivedi, you can take this
I
question.
think he has left. Dr.
Okay,
Sachin. I
maybe
think
some.
there was
Acha,
a
okay,
message on the
okay,
chat. Yeah, I guess he
okay,
has
right,
left.
right. So Dr. Charu, what is your practice in your institute?
So I would agree to what Dr. Sachin Khurana said. Such a bad, ECOG 2, we would generally start with a single, a
Single
single agent,
carboplatin.
and then see how is if the patient improves, and then we sort of take her to the, two drug regimen.
So will you give immunotherapy for this patient? Follow-up question.
I think we can, in the current era, we can
Which
consider
one?
if the patient is sort of, fit to take it, because I think her performance status, she's got COPD, she is
Yeah.
diabetic, hypertensive. I think there were a lot of comorbidities with this patient. So, I mean, if, we can consider giving a TIZO, if,
So
our
if you want to
medical.
add, when you want to add cycle from cycle 1 or cycle 2, if you
No,
want,
I think once the GC improves a bit.
improves.
Yeah.
Okay. Dr. Naomi, your inputs,
Yeah,
any difference?
absolutely the same, although we should not do that, but the reality is that
Yes,
we
it
all do
happens.
that. So absolutely the same. I think the first important thing is to improve ECOG performance status. So sometimes you give just a little bit of carboplatin and they improve really quickly. So and then you can consider from cycle 2 and thereafter to add immunotherapy there.
Right. I think so. We are all agree. And to summarize, yes, we do use single agent carboplatin even in PS3 patients, and they do improve. And then we move to etoposide, add etoposide carboplatin. Mostly, I 90% I use carboplatin in stage 4 patients, and 1 or 2 patients I have used etoposide irinotecan because of CKD, fit patient, of course. And yes, for immunotherapy, fit patient, affordable from cycle or cycle itself. And most of the cases, it ultimately it land up in cycle 2 because it require a lot of discussion, finance, approval, many things. So that's a practical thing. So this patient, extensive SSLC, ECOG2, received carboplatin and etoposide, good tolerance to chemotherapy. There is an improvement in clinical status. If you see the imaging, this phase is also improved, ECOG PS improve. And performance status, yes, we do treat PS3 patient if this is because of disease burden. I will see patient with PS3, if we all agree, right, Dr. Sachin?
Yeah, absolutely. I think we need to determine that the performance status is bad because of disease rather than any other
Comorbidity.
comorbidities. And if it's because of disease, then giving small doses of carboplatin in many of the patients, PS does improve. It's
So there's a follow-up question. Do we do any biomarker?
as of now, since I'm not going to alter my treatment based on biomarker, I would just stick to my standard treatment.
I
As
hope,
of now, I'm not using any
yeah,
biomarkers for
I'm
SCLC.
sure all of us is not doing any biomarker for treatment decision, right? For extensive stage small cell CLC. Dr. Noemi, do you do any NGS? Because NGS nowadays,
No, we would like to, but we are not allowed. Though I think small cell lung cancer right now, it's in the field of biomarkers. It's a really difficult disease because it's more a transcription-based
yes,
field than a pure
classification.
biomarker mutation. So I think right now it's very difficult well, or I think it's not needed to use biomarkers. We can take biopsies. I think it's important to collect information and data, but not to use it as a clinical practice to select immunotherapy, right?
So not outside the clinical trial or any research protocol, right?
Mhm.
Okay, so that should be the message. Would you add immunotherapy? Discuss yes. What are the criteria that can be considered while choosing IOs? We all know that there is no contraindication for immunotherapy, and this is pretty standard nowadays. So patient was started on etoposide, carboplatin, durvalumab, 1500 mg 3 weekly, no toxicity. Would you recommend PCI? Yes, or MR surveillance. So I'll again come to Dr. Charu. Dr. Charu, this patient received chemo immuno, had a very good response, let's say near CR. Would you consider PCI for this patient?
So this patient is 74, I think, if I
Mm.
remember the age correctly.
Yes,
I
yes,
think
76.
I think if the patient would understand, I would want the patient to be on MRI surveillance.
Okay.
If
Now,
we think,
what
yeah,
if 65?
sorry.
If the patient is 65 years?
So, I mean, it's just a number game, you know.
Yeah,
So, I mean,
exactly.
if you see the NCCN guidelines, it says, you
Mm.
know, anyone above 60, you can sort of, you know, put the patients on MRI surveillance. So, we know that we need to have this discussion with the patient
Mm.
that this is what we are looking at,
Now,
why we are recommending, why we are not.
why I'm asking, this is extensive stage. So we don't do PCI in extensive stage, right? As per
So,
the data.
So no, again, I mean, if the patient has responded well, so
Mm.
earlier, till the time this MRI surveillance came in, even the patients with extensive stage who have responded well to chemotherapy would be given BCI.
Okay. Dr.
That is
Sachin
what our
Khurana?
practice was.
Okay, okay. Dr. Sachin, what is your practice?
Uh, PCI in eligible patients who have responded very nicely. But in this patient who have a lot of comorbidities,
Mm.
elderly, I would skip PCI definitely. In this patient, definitely I would skip.
Fine.
Or just go on some kind of surveillance strategy.
But this patient has a liver mets, let's say bone mets, though they had responded very well. Extensive stage PCI, the benefit is, I think there was not there. There was a phase 3 trial in published in Lancet 4 or 5 years back, not right?
Yeah.
Yeah,
But as of now, still we are,
you are
in
using.
young fit patients or yeah,
Yeah.
we are giving PCI
So
even
I'll
in
I'll
excessive.
I'll take opinion for autonomy. What is your practice in there?
It's from me.
Yes, yes, for
Oh,
extensive
sorry.
stage patient. Yeah.
Yeah, no, but I'm not pro PCI in patients
Mm.
with extensive disease. Indeed, in extensive disease, I think it's more debatable in limited stage disease. In extensive disease, we know that we have a negative trial with the use of MRI, and I think the benefits in survival are not clear. So I
Clear.
think in my case, well, if I had a young patient, I could discuss it with him and explain well to him. But in a patient with elderly patient with comorbidities, advanced stage disease, I could not be in favor of using PCI.
Right. So same, we are also not giving PCI for extensive disease patient except if the extensive stage is related to thoracic. So extra thoracic extensive we are not giving unless patient is very young, and that is a rare scenario because yes, there was no additional benefit in terms of survival for in extensive disease, but it is a customized call. You can discuss patient to patient. There are cases where you may consider. Are there any additional factor that you may consider if you contemplate RT for a patient on immunotherapy? Right. So I'll again start with Dr. Sachin Khurana. Sachin, again, this patient, as I said, responded beautifully, and there's only thoracic residual disease. Will you give any consolation radiation to the residual disease?
Yeah, so if the patient, if if the extrathoracic disease is
All
in
CR.
CR, yeah, and if the patient has responded nicely in the thorax also, is young, fit, can tolerate RT, we are referring those patients for thoracic RT.
Radiation.
Yeah, for the residual disease. Yeah, very good partial
Right.
response. No
Yeah.
extrathoracic disease. Yes.
Dr. Charu, is there any data to suggest that this patient had a benefit of?
Yes, there is, and that had shown, a better progression-free survival and even OS. But that was very limited to the patients who had, no extra thoracic and minimal thoracic residual
Right.
disease.
Right. And the question is again in the era of immunotherapy. Yes. Okay. So, Dr. Noemi, your comments.
Yeah, it's the same. I mean, it's very selective population,
Yes.
response to stratotherapy. But I have to say that, for example, you said, do you consider other types of radiotherapy? So maybe we can mention about this. So we are using more and more SRT in small cell lung cancer. That was something that before maybe was not even considered. And I think right now we have scenarios in which patients have relapses or they have localized disease or have a
oligometastatic
response, and then you have one limited metastasis in one side. I think we have to change a bit the way we are thinking with this disease, because probably there are different subset of patients with different outcomes, and I think SRT is more widely used in our center right now in patients with a small cell.
Okay. Okay. Thank you.
Can
So
I ask
this,
one question?
yeah.
Last one. I mean, do we consider the concept of oligomets
In small cell
or not?
Okay, I'll ask the expert. I think we will. Dr. Noemi, let's say one bone mets, one cervical lymph node, or one liver
Well, that's
mets.
what I said. When you say oligometastatic disease, it's not really, well, it's out of the concept of a small cell lung cancer. But I think there are cases and there are case reports and series of patients with a small cell lung cancer with one lesion that experience a long-term response, even in localized disease or in advanced disease, specifically in patients that relapse after a long time in localized disease. They have this oligo
recurrence.
Exactly. And I think there's room in there to try to explore these SRT strategies. I would say always together with systemic therapy. I mean,
Why
give
not?
SRT alone. Probably I would give also, because it's a very chemosensitive disease.
And it's an aggressive
But
disease.
I think there's the concept of oligometastatic disease could exist in the setting of a small cell lung cancer.
Thank you.
Okay. So I think this patient was started on Durva maintenance, 7 weeks in cycle 4, and on has partial response. Continue. This is the disease at baseline, and this is the bulky disease liver mets has responded beautifully to the therapy. How many cycle of Durva will you do response assessment? I think this is pretty standard. We will not go into that. We always check after 3 cycle or 4 cycle. And this will depend whether you do CT or PET. It doesn't make any difference. So I think this was my last slide. If there's any question from our expert, please feel free to chip in. And if there's no more question, I'll stop here. And thank you very much for your inputs and participating in this panel discussion. So back to organizer, Professor
Thank
Raina.
you. Thank you, sir. Dr. Raina has logged out.
Okay.
I would like to thank all the panelists for logging in. Thank you so much.
Thank you. Take care. Bye-bye.
Thank you, Dr. Bivas, and thank you, Dr.
Thank you, Dr. Noemi.
Thank you. It was very
Good to
nice
have you
to
here.
talk with you. Very nice discussion. I enjoyed it a lot.
Thank you.
Thank you. See you again. Take care.
Take
See you soon.
care. See you around. Bye. Bye.
Bye. Bye.